Good afternoon. I'm Dr. Jill Rabin, head of urogynecology at Northwell Health. Welcome to Let's Talk About What's Going On Down There. Our expert panel will be discussing all those topics that everyone wants to know about, but is often too embarrassed to mention during healthcare conversations. From concerns about abdominal discomfort and colorectal cancer, to incontinence and other urinary difficulties, and from sexual health for women to the anxiety associated with going to the doctor. My colleagues and I will provide you with timely and practical information that could change your life. With me today are gastroenterologist Dr. Bethany DeVito, urologist Dr. Farzin Feruzzi, and psychologist Dr. Jennifer McKelvey, who are all Northwell Health's Katz Institute for Women's Health specialists. Let's get started. Dr. Feruzzi, our urologist. What is overactive bladder?
Okay, thanks so much, Dr. Rabin, for including me in this wonderful panel. So overactive bladder is it's a diagnosis, but it's really a constellation of symptoms. They include symptoms such as urinary frequency, so going to the bathroom very frequently during the daytime, urinary urgency, which is the sudden compelling desire to use the bathroom and having difficulty staving off that urge to get to the bathroom, nocturia, which is getting up in the middle of the night to use the bathroom. And in some patients, there can be a type of incontinence, which we can talk about a little bit later, called urge incontinence, which is the inability to actually get to the bathroom in time and then having an incontinent event. So when we talk about overactive bladder, it could be any one of those four potential symptoms or just one of those symptoms.
And if a patient has one or all of the symptoms associated with overactive bladder, what are the treatment options specifically for overactive bladder?
So when we look at and when we talk to our patients about overactive bladder, we think of them as sort of lines of defense. There are first, second, and third line defenses or treatments that we offer our patients. First line treatment options include sort of non-medicinal, non-interventional options such as fluid modification, so altering what the patient drinks to try to reduce some of those OAB symptoms. So things like reduction in caffeine, hot and spicy foods, specific foods that can irritate the bladder, and then also just overall fluid volume intake. We'll assess that with a voiding diary and see specifically how much fluid the patient is drinking and how much urine they're making, and try to alter that to try to reduce some of those overactive bladder symptoms. There's also bladder retraining techniques, which include things like Kegel exercises to try to build up pelvic strength and also dampen some of those urgency-associated urinary symptoms. So those are some first-line therapies that we always start with when we counsel our patients to treat their overactive bladder. The next line or second-line therapies include medicines that we can offer our patients. There's two main categories of medicines that we use. One is called anticholinergic, and there's about 11 or 12 different agents that are on the market. One, for example, is oxybutynin, which is probably one that maybe most have heard of, which is essentially, think of it as an antispasm medication. It helps control that bladder overactivity that causes a lot of those symptoms. The other category of medicines are called beta-3 agonists, which is, again, another pathway to calm that overactive bladder, overactive muscle of the bladder that causes a lot of those overactive symptoms. There's two agents within that field that are currently available on the market. And then when we talk about third line therapies, those are really more advanced interventional options. And that would include two main categories. One is botulinum toxin, or Botox as it's popularly known as. Botox is used most commonly, people are familiar with it for cosmetic use, but we do also use it urologically. I know in gastroenterology field as well, they use it for some indications. The Botox is injected actually into the muscle of the bladder, and just as it does in someone's face when it's injected in the face, it relaxes some of those muscles, specifically in the bladder, and by relaxing them, what's called chemodenervation, relaxes some of that bladder overactivity. The other category falls under the umbrella of what we call neuromodulation, which are there are many neuromodulatory options. Effectively, what that therapy does is via specific routes sending electrical impulses to the bladder, the nerves around the bladder, to again calm that bladder overactivity. Within neuromodulation, there's posterior tibial nerve stimulation, which is an office-based treatment option that we offer our patients, which is done on a weekly basis in the office. And then there's more invasive options, which include sacral nerve stimulation, which sort of in the lay way, we would just refer to it as more like a pacemaker for the bladder, which is also a good third line therapy option. Those third line therapies generally are really more for refractory patients. In other words, patients who've tried in earnest some of those simpler first and second line therapies and have still had persistent overactive bladder symptoms, at which point we can offer them some of those more advanced therapies.
That was very comprehensive overview of overactive bladder. I learned something. And I want to ask you our second question for you. What are the main types of incontinence that women suffer with in the United States?
So there are several different types of incontinence that we see as pelvic floor specialists. I'm going to hone in on sort of two of the main types of incontinence that we see. That would be stress urinary incontinence, which is incontinence associated with any type of activity. So that would be things like coughing or sneezing, laughing, exercising, lifting heavy objects, anything that causes an increase in the abdominal pressure. That pressure gets transmitted to the bladder, and that stress on the bladder causes leakage. That's usually caused by two anatomical issues. One is hypermobility of the urethra, and the other is sphincteric deficiency, both of which basically cause the outlet, which is sort of like the opening of the urinary tract, to be incompetent and not function properly. The other type of incontinence that women typically will come and see pelvic floor specialists for is urge incontinence, which I sort of alluded to when we were talking about overactive bladder or OAB. Urge incontinence is, again, that incontinence associated with the sudden urge to use the bathroom and not get there in time. And there's some triggers that women will sometimes report, such as running water or being outside in cold weather or the sound of the key hitting the front door lock. Those types of triggers trigger that urge, and then they're unable to get to the bathroom in time. So those are the two main types of incontinence. And not infrequently, we see patients who have what we call mixed incontinence, meaning they can actually have both components, either equivalent, meaning the urge and stress bothers them the same, or they can actually have a predominance of one versus the other. So we would say someone who has stress predominant mixed incontinence has primarily stress incontinence that bothers them with a smaller degree of urge, and vice versa for patients who have urge predominant mixed urinary incontinence.
That's very comprehensive. You went through the treatments for overactive bladder, but I would like you to elaborate on a little bit more on the different treatments available specifically for stress incontinence or stress predominant urge incontinence.
Right. So stress incontinence or stress predominant urge incontinence, again, it being essentially a anatomical issue, there really are no medicines available for that, like we talked about for overactive bladder. So it's really a matter of trying to address the anatomical deficiency that we're dealing with that's causing the stress incontinence. So the first thing, just like we talked about treatments for overactive bladder, as physicians, we try to employ the least invasive option first with our patients. So mentioning before, Kegel exercises, so pelvic strengthening exercises can sometimes increase the pelvic strength, and by doing so, improve some of those stress incontinence symptoms in women. And either we can teach patients how to do Kegel exercises in the office, or sometimes more advanced pelvic strengthening techniques by helping them see a pelvic floor physical therapist. Another non-interventional option would be the realm of vaginal inserts. So that would be either in the form of anti-incontinence pessaries or anti-incontinence inserts. So that's essentially placing something inside the vagina, like a pessary, which is a rubber ring that can apply support to the area that's lacking strength and stopping the incontinence by using that. There are also different vaginal inserts that are used that are softer, again, placed almost like a tampon, but a little bit more firm version of what would be a tampon, again, by applying pressure to the urethra intravaginally to afford some more continence. So those are some of the non-interventional options. And then in patients who either have tried some of those initial therapies and have failed, or maybe wish to have more definitive success for their stress incontinence, there are surgical options. The two main sort of categories of surgical options would include bulking agents. So that's a procedure where endoscopically, no incisions are made in the body. A small camera is placed into the urethra, and effectively small bubbles of implants are placed alongside the urethra to support the area that's weak. So those are bulking agents. And there are newer ones that are coming out on the market. One that's recently come out in the last year, which has had some more success compared to previous bulking agents that have been used. And the other option is slings. And those are different forms of slings. There are mid-urethral synthetic slings, which are exactly how they're termed, synthetic. They come in a box. Or there are fascial slings. So making a sling or a hammock, if you will, out of the patient's own tissue. So that's essentially a transvaginal procedure where that sling is placed under the urethra to support it, so that when there's coughing or moving or exercising, there isn't incontinence as a result of it because of that support that's placed there.
Very interesting. I like the distinction between the synthetic and the fascial sling. Very, very interesting. So those are a lot of choices. So really, they're quite important for patients to know their diagnosis and get a treatment plan with someone they can talk to. It certainly seems you are a urologist who people can talk to and ask questions and bring questions. So this has been wonderful. I have one final question for you. What is pelvic floor dysfunction and how is it treated?
Yes. So that's actually a quite common issue we see in our office, pelvic floor dysfunction. And it's, simply put, it's effectively two things that are going on wrong with the pelvic floor or the pelvic floor muscles. One is the inability for the female patients to properly relax their pelvic floor in terms of moving their bowels or voiding, urinating, as well as an incoordination of those muscles. So when you have a combination of inability to relax and an incoordination of those muscles, that could actually affect a lot of pelvic floor functions, mainly urinary function and bowel function, and possibly maybe Dr. DeVito can talk a little bit about, the bowel issues associated with pelvic floor dysfunction. But in women with pelvic floor dysfunction, we commonly see voiding issues because the bladder is we look at it as a bystander, something that's affected by those pelvic muscles that aren't working properly.
Well, I want to thank you for being with us today and invite you to stay on, and other questions may come up. That's all I have for you at this point. So we're going to move on to Dr. Bethany DeVito, our gastroenterologist, and ask her some questions, 3 questions specifically. So Dr. DeVito, welcome. Thank you so much for joining us. Thank you for joining us. Wonderful to see you. I have a couple of questions for you. This is also, just as incontinence is extremely important, bowel health is extremely important, and they basically work together, bladder and bowel, and the pelvic organs in terms of uterus and so forth. But I'm going to confine my comments to your specialty right now. I'm going to ask you a few questions, such as, why might women in particular have symptoms of abdominal pain and bloating? What might they mean? When should they worry? And when should women see a doctor for advice?
Yeah, so thank you, Jill, for including me here, by the way. I would say that most women come to see me. Number one complaint is usually abdominal pain and bloating. If I had a cure for bloating, it would be like a wonderful world for women, quite honestly. So bloated stomach is that feeling of fullness in the belly, tightness, pressure. It may or may not be accompanied by visibly distended or swollen belly. Some women actually tell me that they feel pregnant. and then it goes away later on. And the feeling can be a sensation of just feeling mildly uncomfortable to intensely painful. Some people actually end up in the emergency room with this feeling of being really uncomfortable. Usually it goes away after a while, but for some people, it is a recurring problem. I would say the most common cause of stomach pain and bloating is due to excess intestinal gas. And this is usually caused by either eating too much or eating too fast, or could be caused by a food intolerance. I always tell my patients who comes in with complaints of bloating, you are what you eat. There's something in your diet that you're not tolerating well, and you have to evaluate your diet. I would ask them about dairy products, how much dairy they have. Lactose intolerance is very, very common, especially in certain ethnic populations and as one gets older. So lactose is sugar found in milk, cheese, yogurt, ice cream. A lot of people have symptoms of lactose intolerance, gas, bloating, and even urgency when you have too much of milk. In some people, it's fructose intolerance. They have too much fruits and vegetables, or people who, let's say, drink too much fruit juices or have dried fruits, or gluten intolerance. People tell me, I think I have celiac disease. And I ask them why. Because when I have bread, I get gassy and bloated. There's not too many celiacs out there. So gluten is a protein found in wheat, rye, barley. And celiacs basically have just make it simple, and so like an allergic reaction to gluten, in that when they have gluten, it damages their small bowel, and with that they get anemia, diarrhea, symptoms of bloating. There's not too many celiacs. There's a lot more people who are gluten intolerant. So I tell people, go on lactose-free diet. Elimination diet is the key. 2 weeks lactose-free. If it's not enough, 2 weeks gluten-free. And if it's not enough to help you, do a food diary. See what makes you feel bloated and gassy. A woman's menstrual cycle is another common cause of temporary bloating. Right before menses, a lot of people complain about being bloated, and my constipated patients, believe it or not, go to the bathroom better. And that has to do with the imbalance between estrogen and progesterone just before the menses. Many women also suffer from a condition called irritable bowel syndrome, or IBS. And other terms used for that, spastic colon, nervous stomach. So women with this condition will complain of chronic abdominal pain, usually pelvic pain, lower abdominal pain, cramping as if they're having their period, bloating, and they have symptoms of either diarrhea or constipation. So many causes for bloating, but I would say probably the number one cause, diet.
Very comprehensive answer, and very reassuring, I might add. So let's take a little bit of a deeper dive into the subject and talk about colon cancer screening. When should a woman start screening for colon cancer?
So colorectal cancer is the third leading cause of cancer deaths in both men and women. So it's very common, and it's a very preventable type of cancer. So recently, the American Cancer Society and the U.S. Preventive Services Task Force have lowered the baseline screening age for colon cancer from age 50 to age 45. Reason being is we're finding younger and younger people developing colorectal cancer before they're 50. It's been estimated that more than 10% of new colorectal cancer cases occur in people younger than age 50. So we want to catch them early because it is a very preventable type of cancer.
I understand there are some new guidelines, some even newer guidelines for average risk people.
So the average risk, we used to screen starting at 50, and now we start screening at age 45, unless there is a high risk for colon cancer, meaning that they have a family history of colon cancer or colon polyps. And those we start screening at age 40 or 10 years younger if their affected relative, first-degree relative is young. Like, for instance, if their mother, father, brother, sister had colon cancer at age 45, we would start them at age 35.
I see. I want to just jump in here with a little bit of an extra question. I know you probably hear this all the time. I certainly do. As a gynecologist, a urogynecologist, when I recommend a colon cancer screening for my patients, the first thing I hear is, "Oh, I really hate the prep." Can you talk a little bit about the prep?
So it's gotten better. People think about the prep as a gallon of nasty tasting a liquid. We actually don't use that unless, of course, it's the cheapest one. So unless, of course, they want the cheapest possible and they don't want to pay for anything more expensive, because that's covered by insurance most of the time. But there's other preps out there. There's something called soup prep, which is basically 2 little bottles of 6-ounce fluid. It tastes to me, because I took that prep myself, like salty Robitussin type of liquid. And there's a new one called Clinpic, which is cranberry flavored, and most people will say it's sweet and salty, and it's 5.5-ounce fluid. 2 of them that you don't mix in anything. You drink it straight up and follow with 3 glasses of water. So it's very small volume. The bottom line with the prep really is the day before. Everyone's supposed to be on a clear liquid diet. The most important thing is hydration. Hydrate the day before with clear liquid fluids to prevent feeling sick while they're drinking the prep. Because if they're dehydrated because they're not drinking their fluids the day before, and then now they're drinking a laxative that gives them lots of diarrhea to completely clean them out, they feel ill and they don't feel well and they get nauseous and they may vomit the prep. So hydrate well. And then you talk to your doctor about the different preps that are available, because some people have aversion to taste and some people have aversion to volume. So I would ask them individually, what is the issue? Is it the volume or is it the taste? And I will work with them. And there's also an over-the-counter prep called Miralax. Miralax we use for chronic constipation. It's powder. They mix it with any drink that they want, water, Gatorade, juices, vitamin water. So there's different ways of prepping now. So it's really not that bad.
Such good advice, especially the part about hydration. I didn't realize that was so very important. So thank you for emphasizing that. A last question about colon cancer. Risks. What are the risk factors for developing colon cancer, and how can a woman reduce this risk?
So the biggest risk is genetics, family history of colorectal cancer or colon polyps, history of inflammatory bowel disease. And those are people with ulcerative colitis or Crohn's colitis, and people with a genetic predisposition to colon cancer like Lynch syndrome or familial adenomatous polyposis. A woman can reduce risk simply by getting screened. Get screened at age 45 or earlier if they have risk factors for colorectal cancer. Getting regular exercise will reduce risk for cancer and most cancers out there. And take control of your weight. Obesity is a risk factor for colorectal cancer. Eating healthy diet rich in fruits and vegetables, avoiding red meats or eat less of it, and processed meats, and avoiding smoking and alcohol.
Of course. So again, just to kind of wrap up this segment, this part of the segment, what is your best advice for women to maintain a healthy gut?
So gut health is so important because more than half of our immune system is in our gut. So keeping our gut healthy will prevent us from getting many diseases down the line. And we can improve our gut health by eating a balanced diet rich in fruits and vegetables, and which will provide the fiber that builds good bacteria and gut health. Other foods that can build a healthy digestive system include fermented foods like kefir, which is basically like a fermented milk drink that's similar to yogurt and rich in probiotics. Other fermented foods are such as kimchi, sauerkraut are also good for the gut health. Managing stress levels. So experts in gut health often talk about the brain-gut connection and refer to the gut as the second brain. Research suggests that anxiety and depression are affected by the gut and vice versa. So anyone with IBS knows that when they're stressed or upset or anxious, it triggers their symptoms of abdominal pain and bowel changes like diarrhea. So maintaining, managing stress is definitely a very important point. Exercising, because exercise, physical activity will keep the colon moving and will keep the bowels moving. Also, not eating too much, meaning eating smaller, more frequent meals to avoid overwhelming the GI tract, drinking plenty of water, limiting alcohol and caffeine because those can be toxic to our system. And of course, with anything else that we lack and we need, get more sleep.
This has been wonderful. I actually have one final question for you. And that is, my patients who are older in their 70s will ask me, when do I stop screening for colon cancer? So yes. Is there an age cutoff?
So there's not per se, but it's only a recommendation, meaning at ages 76 to 85, you have to individualize. So at 76, I always look at my patient and look at their physical health and their history and outweigh the risk benefits of screening. So we have to individualize screening after the age of 76. So 76 is the age where we say, do you need to be screened or not? And I can tell you there are a lot of 76-year-old out there or 78 or 79-year-old who are very, very healthy. And people are living much, much longer now. So you do have to look at their physical status and individualize.
Great. Well, this has been so helpful, and I appreciate you being willing to talk to us today. I know you're extremely busy, as is Dr. Ferruzzi. Appreciate both of your participation, but if I could ask you to stay on for the rest of the time, because we may have some questions for you. So thank you again.
Thank you.
Thank you.
So now we're going to talk about sex. What is sex is my first question that I'm going to attempt to answer. So, sex and sexuality is an integral part of the personality of everyone, man, woman, and child. It's a basic need and an aspect of being human that can't be separated from other aspects of life. However, it hasn't really been recognized by most healthcare providers as a real medical entity. And there are reasons why we don't bring up our sexual concerns with our doctors. We're concerned that there may be no medical treatment for the problem. We're concerned about our doctors may dismiss us or laugh at us, God forbid. And if that's the case, it's important to come to your doctor with a list of questions and make sure you're being taken seriously. I've heard from patients that I don't want to upset my doctor. Well, you know, who is the patient here? It's the doctor-patient relationship. It's a relationship. You have to be comfortable. Try your best. Try to be comfortable. Bring your questions. If you're not comfortable, it may be time to find another doctor. And that is another reason we may not bring up our concerns. Healthy sexual functioning improves self-image, nurtures our relationships, and increases our motivation to take better care of ourselves in other areas, such as with diabetes or hypertension. Menopause and aging may compromise our healthy sexual functioning. Because of this, it's important to bring up our concerns with our doctors and to take these seriously. So there's a big difference between men and women. I think we know that sexually, and as we age, things do change. We want to be appreciated. The brain for women is actually the most important sexual organ, and the connection between the brain and the genitals is totally crucial. We desire intimacy to achieve orgasm for many of us. As opposed to men, a release of orgasm for them is a stress reliever and also may involve intimacy, of course, but it's mainly used to relieve tension and reduce stress. Women, basically, there's an intimacy-based model of female sexual response where we can jump in at any part of the cycle, including emotional intimacy. We may see something that turns us on, sexual stimuli, spontaneous sexual drive, arousal, biological and psychological factors, but mainly we need our minds and our bodies to interact. Very important. There are some myths about sex that it always involves a younger couple, always involves a couple. We can be sexually active by ourselves and have a wonderful relationship with ourselves. A myth is that sex involves male and female, and that it only happens in the bedroom. Well, we know from when we were younger that there are lots of other places besides the bedroom that sex can happen. So basically, desire is very complex. It involves your body image, your life experiences, your health, hormonal changes, and so forth. However, sexual desire may be negatively impacted by depression, by antidepressive medication. Don't change your medications. Talk to your doctor, but this may be a factor. Stress, of course. We know that stress impacts sexual functioning. The quality of your relationship and declining and changing hormonal levels as well. So it's very important to make sure that your relationship is a good, if it's with another person, regardless of gender, that it is a good, healthy relationship, and that there is no intimate partner violence or domestic violence. In that case, it's important to talk to someone, get support, and get help. The second question is, why does my vagina seem different in menopause? What about orgasm? It takes longer and so forth. Why is it so different? Well, it's similar to the first answer, that there's a balance between our brains and our genitals, that there's a balance between the cardiovascular system, our lungs, our musculoskeletal system. It may be more difficult to get into different positions when we were younger, maybe easier. It may be very difficult now because of arthritis and so forth. And there's an impact on the endocrine system and hormones on our sexual functioning. So if you have a thyroid disease that is not controlled well, you may have difficulty achieving orgasm. If you have diabetes that's not controlled well, it may be difficult to achieve orgasm. We are complex creatures. We like variety. Many of us crave romance. Sensory stimulation is important, communication with ourselves or our partners, and you have to really be in the mood. And technique is very important, and a lot of foreplay, especially in menopause, is extremely important. And of course, we don't want to forget about passion. The third area I want to address is sex as we age. What's important to know? As we go through menopause and as we age, we do change in terms of orgasmic potential, vaginal dryness. Our vaginas may get less elastic. We may have pain or burning with sexual activity. We may have an increase or decrease in clitoral sensitivity and orgasmic response, and a change in libido. Well, it's very important to make sure we walk around with our vaginas every day, and yet we just use lubrication sometimes for sex. Well, lubricating your vagina with sex only is like trying, with a menopausal vagina, is like trying to land a plane on an icy runway. You can't do it. So it's very important to moisturize your vagina like you moisturize your face. Most of us put on some cream or something most nights. Put a moisturizer in the vagina. There are many over-the-counter ones that are non-hormonal. To do that a couple of times a week, and lots of lubrication and lots of foreplay for sex. You may have a hormonal imbalance. In menopause, estrogen levels go down, and there are treatments for those. You can take an estrogen hormonal replacement therapy as long as it's with your physician and there's no problem with any vaginal bleeding and your mammogram is normal. The most useful vaginal estrogens I have found are not even oral or the patch, although those are available. They're vaginal estrogens, and they come in the form of the vaginal pill that you put in the vagina twice a week. Or a vaginal cream or a vaginal ring. And the ring is used for 3 months, and then you take it out, throw it away, put in a new one. And those may help the vagina tremendously, in addition to moisture and lubrication. Moisture during the week, lubrication for intercourse of any or sexual activity of any type. And again, thyroid function is important. That's very, very important for women to check that. So in terms of safe sex, I want to finish the last few parts of my portion of the talk to mention that women still can get sexually transmitted infections even if you are older. And that goes for if you're a widow and you're dating a widower and you're sexually active, or you're a widow and you're dating a widow. You still can get a gonorrhea and chlamydia and syphilis and AIDS and hepatitis from your partner, whether or not your partner is the same gender or different gender. Okay. And it's very difficult to have this conversation with your partner, especially, they look nice. I hear this all the time from my women in menopause. Oh, he looks so clean. He's only been with one other person. Go together you go to the gynecologist. He goes to the internist. You both get tested with urine test for chlamydia and gonorrhea and blood test for example, AIDS and syphilis, for example. Very important to make sure you're both healthy. Now, if he or she does not want to go get tested, what does that say about their commitment to you or their feeling about you? So if somebody doesn't want to get tested and says, I'm fine, I don't need to, you have to think about the relationship. You don't necessarily have to end it, but you do have to think about it in a little bit of a different context. I want to talk about the fact that the highest rate of unintended pregnancy for women is in the 40s. So if you're missing a period and you think you're in menopause, it may not be menopause. It may actually be pregnancy. Very important. I had a patient come to me with hot flashes, and I said to her that I would help her with her hot flashes in 4 months when I delivered her baby. She was 48 years old. So if you're having heterosexual sex, and you're in your 40s or you haven't reached menopause, for some women, early 50s, average age of menopause in the United States is about 52. So if you're still menstruating at least some of the time, you may have the ability to get pregnant. So make sure you're using a contraceptive. Very, very important. We don't want to assume that everybody is heterosexual either. Sometimes in menopause, women decide that they would like to try to have a relationship with another woman, and same for men, as a matter of fact. So we don't assume that everybody is purely heterosexual. Actually, 12% of the population reports in menopause same-sex attraction or behavior, and a change in sexual preference may occur in menopause, actually. So just remember that a good sex life and a healthy partnership can boost your life force. So what goes around truly comes around. And passion is connected to the heart, soul, brain, and genitals. Dr. Jennifer McKelvey, welcome. I have a couple of questions for you. My first question is, we know that the physician-patient relationship at its best is based on trust and that it's important to be transparent. But what if my feelings get in the way of being honest with my doctor?
That's a really great question. I think it is important to separate in these instances, separate the emotion from your behavior. So if you can think of a time when maybe you got really angry at someone and yet you still had to be nice to them or civil, at least, that's an example of separating the emotion from your behavior. So realizing that you can have an emotion that we view as negative, like anxiety or fear, and still speak despite that fear. And then, in thinking about this, I also considered the fact that we get hung up on words. So words can take on a lot of discomforting connotations. So if you think of the word like vagina or penis, people might not be comfortable saying those words. And so my suggestion at that point is to practice. It might sound a little strange, but practicing saying the words can help sort of separate any of the connotations you have with it with the actual word. So you can sit in a room by yourself and just keep saying the words that you're most uncomfortable with out loud, over and over and over, as loud as you can, until they sort of stop having any real meaning to them. And then just practicing that leading up to your appointment with your doctor. And an initial way you might get used to doing this is using the word milk. So we're all fairly comfortable with the word milk. But if you sit and for 30 seconds, as loud as you can without screaming, say milk, 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 milk over and over and over, it just starts being sounds, and has, with the words that you're uncomfortable with, will allow you to work with that discomfort and have it become less over time.
I have another question for you. Things have happened in my past that make it nearly impossible to go to the doctor, even though I know I need to go. What can I do about this?
That's a really, really tough situation to be in. So a lot of the time when we think of things that happened in our past that make going to the doctor uncomfortable, it goes along with some sort of trauma or traumatic experience, or just a phobia of things. So with past history of trauma, if a person is not already in treatment, I typically suggest getting some trauma-specific treatment so that you can address those issues, because it's fairly rare when a person has trauma in their history for it to only affect one area of their lives. It often affects other areas as well. So getting connected with good trauma-informed treatment is really important. And then with phobias, there are also excellent therapists out there who treat phobias, and addressing that phobia is also very important. It's hard when you have those overwhelming sort of memories or flashbacks or fears that subsume everything else to be able to even make an appointment with a doctor. But with appropriate treatment, it can help you in the future in, taking care of your physical health. And you can also seek physicians that are sensitive to these issues. So you don't necessarily have to go into the detail of the trauma that you experienced or in the past, but you can let them know that you have trauma related to the lower half of your body or the upper half of your body or that type of thing. And there are practitioners and physicians who are very, very sensitive to these things and will do everything in their power to make the experience as comfortable as it can possibly be. And then there are also physicians who are also very sensitive to phobias. So seeking out those individuals, whether it's through word of mouth or talking to your therapist or talking to a psychiatrist, who can help get you connected to those providers that will, follow your guidance on the things that you can deal with and the things that maybe you can't at that moment. And then if you're comfortable with it, looping in your psychiatrist or your therapist to help you have that conversation with them. So everyone is very clear on how to make the best of what can be a very challenging experience.
I have one final question for you. What if a patient says, I get anxious when I go to the doctor and I forget what to say? How can I deal with that?
Well, I've had that come up quite a bit, not just for people I work with, but friends, family, myself. So even if you don't have anxiety, if you've ever had the experience of walking out of a doctor's office and going, darn, I should have asked them about this particular thing, right? So I would suggest in the day or so leading up to your appointment, making a list of questions that you would like to ask. And, maybe if you tend to do your best thinking at night or as you're trying to fall asleep, have a notepad next to your bed so you can jot things down so it's not keeping you up trying to remember them. So that's a good way to do it. You can put it on your phone, type it into your phone, or take a picture of your written questions so that you don't forget. And then if you're just generally anxious about going to any doctor, which many people are, see if a friend or family can go with you. And if you are comfortable with it, discussing with them the questions that you would like to ask the doctor and having them help either prompt you in your visit with the doctor or in some cases ask the question for you so that you can get the information that you need. And then with the responses, you can either that you get from your doctor, you can either write them down or ask your friend or family member to jot them down, because if you're expecting good news, bad news, absorbing all of that information can be really challenging. So it's really important to have sort of just those little tools that you can use to help yourself both ask the questions and then retain the information that's provided to you. So I think that is sort of the best way to go about it. And also to call your doctor afterward. And if you forgot something or misunderstood something, some directions that you were given later, just call. And a lot of doctors are willing to answer. Or if there's a portal for the electronic medical record, often you can email your doctor that way. And so those are just some little things that you can do to help you get through a doctor's appointment.
Thank you, Dr. McKelvey. That was very enlightening and much appreciated.
And thank you. Thank you for having me.
So thank you, Dr. Ferruzzi, Dr. DeVito, Dr. McKelvey, for this very informative session. You have provided tremendous insight into these very vital issues. And thank you, our audience members, for your attendance and attention and participation. We know your time is valuable, and we appreciate your spending your time with us today. Please remember to keep in mind the colon cancer screening guidelines and what you can do to promote your gut health. The importance of transparency in the patient-doctor relationship, understanding pelvic floor problems and what can be done for them, and finally, ensuring your sexual health for a lifetime. Be sure to tune in to the other conference sessions. We hope that the rest of your day will be wonderful. Thank you so much.